The epidemic of cardiovascular disease in India is advancing rapidly. Angioplasty is one of the life-saving procedure done in patients with blockages in arteries. We have with us Dr. Parneesh Arora, Senior Interventional Cardiologist. We would request Dr. Parneesh to explain us about angioplasty and its procedure.
Good evening, friends. I'll take this opportunity to tell you something about a procedure which is becoming increasingly common with our nation. This is known as angioplasty. This is done usually for arteries which are showing significant blockages. There are two settings in which it is done. One is elective, that is the patient has an angiography done already and it shows a significant, usually more than 60% blockage in a major coronary artery. The second setting is that of a more common emergency which is known as heart attack. And in this situation, the best treatment of choice anywhere in the world is to take patient directly to cath lab and open this artery, and this procedure is known as primary angioplasty. I will tell you something how it is done so as to dispel many false notions that it's a very risky procedure and that there is lot of pain during the procedure, and that is why most of the people don't get it done. It's a non-surgical way of opening the coronary arteries. So in this we see that there is no scar after the procedure has been done. It's a very low risk procedure if we compare it to the surgical counterpart, and that the recovery is very early. You can start moving as soon as the next day after the angioplasty has been done. Patient is admitted usually on the day of the procedure, and we tell the patient to take a light breakfast and then report to the hospital. Their fasting should be about 3 to 6 hours. We take screening blood test to rule out any significant contraindications like patient having low hemoglobin or having intercurrent infection or a patient who has added comorbidities. We also take a targeted history so that we come to know whether the patient has serious comorbidities like previous history of GI bleed or has had a major surgery done within the last 6 weeks or so, or has a history of cerebrovascular accident. But once we know that the patient has no major contraindication, we shift the patient to a room which is known as a cath lab, and this has a source of rays, X-rays, with which we can film the coronary arteries after giving dye. It is usually done through the groin, and this excess is then known as femoral artery, or it can be done even through the wrist or hand, and this excess is known as the radial artery. We take antiseptic measures, we clean them with the help of an antiseptics and drape the patient so that the patient doesn't get any infections. To take care of the pain, we give local anesthesia at the site, and once this is done, we insert a small bore needle through which we place the sheath, and this gives us a continuous access to the artery. A blood thinner is usually administered before starting the procedure so that there is risk of clotting is reduced. Blockages look like deposits which are seen in the sides of the vessel wall. Most commonly the femoral artery is, as I said, is the selected site. Through the femoral artery we take a guiding catheter and take it right to the coronary artery, and through this guiding catheter we insert a very fine wire which is 0.014 inch. Over this wire we insert a balloon to widen the passage. Once the balloon is across, we inflate it and then we withdraw the balloon. This is followed by implantation of a stent. The stent is usually delivered over the wire, and once we reach the site, we deploy the stent by inflating the balloon over which the stent is there at very high pressures. The stent is usually selected after seeing the size of the artery and the length of the blockage to be covered. Once the stent is implanted, we withdraw the balloon and the wire along with that. Once the procedure is done, the stent sticks to the wall, and then the patient is the guiding is withdrawn, the wire is withdrawn, and we shift the patient to the CCU or recovery as it is called. The patient is kept in CCU usually overnight, and the sheath is usually removed after 4 hours. After overnight monitoring, the patient is shifted to the room where they are kept usually for 1 day, or the patient is mobilized immediately. The patient can be discharged the same day, or as in most hospitals, the next day. The patient can resume normal activities again the same day, or most probably the next day, and this includes walking, doing routine activities, or even driving and joining work. There are no long-term sequelae or bad effects because of the procedure, unlike surgery where you have a scar and then you may need almost 6 weeks for the recovery to take place. Hence, my friends, it's a very safe procedure, and wherever feasible and wherever indicated, it is the procedure of choice. Thank you.